surrogate marker for glycemic control. I would like your views whether in future A1C would still be the biomarker for control, or the newer tools like CGM and time in range may replace it. And let me start with Dr. Sanjay Kalra. So what do you feel? And then we could have each one speak on A1C versus TIR as such.
Thank you, Dr. Rajiv. And it's a pleasure actually being part of such a panel. We're able to meet old friends and make new ones as well and learn from each other. HbA1c has been the gold standard for assessment, for the past so many years. HbA1c is a target because that's what we try to achieve. But HbA1c is also a tool. When you look at some of the guidelines, you see that based upon the HbA1c, you're able to decide whether you want to give single drug or 2 or 3 drugs to start with. So HbA1c is a tool to help you in decision making as well. There are newer tools which are coming up. For example, time in range based upon CGM. They will have their advantages, but I do feel that HbA1c is going to stay. It's very easy to do an accurate HbA1c, of course, provided that you use the right assay. And Dr. Sujoy Ghosh runs one of the best endocrinology laboratories in the whole country. So perhaps he'll talk about that. You should know the limiting factors. For example, you cannot use HbA1c in patients with hemoglobinopathy, in those with severe anemia, perhaps in those with chronic renal failure, it may not work out so well. But it's a drug that is there to stay. Do not focus only upon HbA1c. We talk about something called the glycemic sixer. So here we have three target-oriented numbers: fasting glucose, postprandial glucose, and HbA1c. We have to focus on them. Like a batsman has to score sixers off every run, off every ball. But if the batsman gets out at the first ball, there's no point, even if he knows how to score sixers theoretically. So there are 3 caution-based numbers as well. You have to minimize hypoglycemia, minimize nocturnal hypoglycemia, and minimize glycemic variability. So if we look at all these 6 together, with HbA1c being the easiest one to monitor in the long run, then that's what constitutes good diabetes practice.
Thank you, Dr. Kalra. Dr. Joshi, would you like to add onto this HbA1c and TIR and CGM? No.
Well, I think Sanjay has very nicely made the sextet and explained it very well. But you see, growingly, we are seeing that time in range is here to stay. In the type 1 diabetes world, I think it is there to stay. In the type 2 diabetes world, it is more on the sextet, and probably beyond sextet, looking at blood pressure, lipids, and many other things. But I think in the type 1 diabetes world, insulin using world, the technology world, I think time in range is here to stay. Now remember, the glycemic variability is well established only in the world of critical care, where the evidence base is robust and sustained. In outside of that, that evidence base is lacking. And as Sanjay has very rightly said that, in India is a vast country with anemia, which impacts A1C. That's number 1. Number 2, India is a country with a lot of hemoglobinopathies. And I'm sure Sujay, who runs one of the best assays in India on the A1C, will tell you the lacunae which some of these typical BioRide HPLCs have in terms of the interferences and so on and so forth. So A1C will still stay as a gold standard. I don't think we can change that, because the whole treatment paradigm of diabetes is based on A1C. But I think, as Sanjay rightfully said, that we have expanded and there are 6 hands of expansion, 5 more than A1C, and that's where we are. And I think we should stay put at that. The ADA only adds more, but I think beyond that also more biomarkers will come. See, fructosamine really never stood the test of time, and many others which came also never really were robust enough to stay there. So I think A1C will stick there still. Time in range probably is a decade from now, if the technology is easily accessible, reproducible, accurate, may be there. But I am not so sure still. I think it will complement. As Sanjay said, we need all the 6 points in management of a patient, because we are all here for people living with diabetes. So I think I agree with Sanjay, and I'm sure Sujay will add some more pearls of wisdom on the methodological limitations of the A1C, which we see in current practice because of the low hemoglobinopathies which we see in our country, and many more conditions, like a simple leprosy drug like Dapsone can have an erroneous A1C and many other things. So as long as we know limitations of A1C as an SA, I think it still will be there for routine care. It will still stay, but we have to look beyond that. Thank you.
Thank you, Dr. Joshi. Dr. Ghosh, Sujay Ghosh, would you like to add on? So we'll come to you at the end. Yeah, yes, Doctor.
Couple of things. First of all, we know that diabetes is like a marathon. You're not looking at just what's happening in 1 day or 2 days. So you need something which gives you relatively longer duration of controls idea. So the best that we have of that right now is A1C. The rest of the markers are, either a day to day or 2 weeks or 3 weeks, like that. That's number one. Number two, in addition to deciding upon what treatment you're giving, it has a definitive role in diagnosis of diabetes. You have cutoffs on the basis of which you are defining someone that this is someone who might have diabetes. So for screening and diagnosis of diabetes, the second thing. The third thing in terms of prediction of complications. I think we've had data generated over decades now to tell you, if you have a higher level of A1C or each 1% increase in A1C, this is what's the risk of increase of microvascular complications, whether it's retinopathy or neuropathy or otherwise. So these would be three things, whichever new tool we talk about has to achieve these before you can think of even replacing or supplementing A1C. In terms of methodology of assay, I agree and I accept that there might be fallacies, but it's still probably the best of the worst. And even if you're talking about hemoglobinopathies, if you are aware that this is someone who's got hemoglobinopathy, either don't do the test, and even if you have it, serial tests will help you. Even with a hemoglobinopathy, switch over to other methods rather than HPLC. For example, the immunoturbidometric method in an individual with known thalassemia might be able to give you better results. And you're looking at serial results, not necessarily a one-off result. So that would be my take on A1C. And the fact is, this huge body of evidence that we have developed over decades, wherein you have kind of looked at A1C as the prime target or the prime marker of what's happening, it's going to take a lot in terms of, overcoming that. And like Dr. Shashank said quite correctly, in a type 2 diabetic individual who's not getting insulin or a sulfonylurea, I don't think there's going to be much role of time in range. That's my personal opinion. Beyond, say, doing an SMBG, you can even do a 7-point SMBG, because again, we are back to the fact that it's all about economics as well. Most of your patients would be doing well. What additional huge amount of, change are you going to put in? People on insulin pumps, yes, definitely there's going to be a role of time in range. People who are on basal bolus or multiple doses of insulin, there might be a role of that. People with organ dysfunctions, there might be a role of that. And even in short-term situations, like for example, someone's pregnant, maybe there it will be having a greater role. Because even if you're looking at time in range, this individual will be having to wear that instrument continuously to try and tell you what's happening actually in terms of your management.
True.
In terms of your adjustment. So that would be my take.
Thank you, Dr. Sujay Ghosh. Dr. Bipin Sethi, again, both these, when we're talking about HbA1c, you're talking about blood glucose. When we talk about CGM, we're talking about interstitial fluid glucose. What would be your take now, your final take on all this?
No, it's not the final take. What is a gold standard? A gold standard is something which is by and large unbeatable, and therefore everything compares with that. For the sheer applicability, given the huge numbers of diabetics that we have, I don't think even it will be replaced in the coming few days also. The limitations of the newer CGM-based data have been discussed. It adds a new way of looking at how things are. It will be nice. But you see, like ECG has not been replaced by Holter monitoring. Similarly, I don't think that HbA1c is going to be replaced. It is available with its own limitations across the world. It can be standardized very easily. It is economical, and it can be done again and again. You don't have to wear an instrument for it, and it has many other advantages over the glucose. All that we know. So as far as HbA1c is concerned, I think it is a standard tool for measurement which can be utilized over a period of time across continents, across countries. And in numbers that we require, it is not easy to replace this particular parameter. It has its limitations, but those limitations can be easily overcome. Like everything, it can supplement and supplant. It can be chosen as a number, which is very good. If you diagnose someone with a glucose value and try to monitor him with HbA1c, it confuses him. But if he's diagnosed with HbA1c and you follow him with HbA1c, this doesn't come as a news to him. So if you're diagnosing based on fasting and 2-hour glucose value, and you suddenly after 6 months raise this issue of HbA1c, he says, "What is this?" But you diagnose someone with HbA1c, you chose a drug or drugs based on HbA1c, you decided a target, then he knows it's a seamless transition, and I think it's here to stay.
I think I agree with that. These numbers, they are a target in themselves, but they are also a way, they are milestones to reach a particular target. And the final target is not HbA1c 7. The final target is good health. And that definition of good health is something which is difficult to put in words. So we should use these numbers, these tools as ways to achieve good health. Yeah. And they represent good health, but partly, not fully.
What's the panel's take on point of care machines for HbA1c? Let me start with Sujoy. A very short 20-second answer.
I think if you look at the NGSP website, it now clearly tells you which of these machines are approved in terms of point of care, because you have so many machines which are there. Not all of them are approved by the NGSP as standard machines. There are, I think, 5 machines which are now currently available in India, which have been approved by NGSP as machines that you can use as point of care. So that's one thing that you have to actually look at. The second thing with regards to all of the assays, whether it's point of care or whether in the lab, whichever machine you are using, please go to the NGSP website, because it gives you cutoffs for each of these hemoglobinopathies. For example, Biorad will come and tell you, we don't have interference with hemoglobin C, hemoglobin S, or hemoglobin E, right? But it only, if you go to the NGSP website, will you know what percentage of that particular hemoglobin up to which there is no interference.
Okay.
So you will have to find out, and ideally, I don't know why the labs don't give this information when they print out the report. For example, if it's a Biorad D10 result, it should clearly tell you these are the interferences. It's just 5 or 6 lines. I think that is something that should be done. For example, if the bilirubin is more than 32 with the Biorad machine, it's unreliable. If the triglyceride is more than 2,500, it's unreliable. So these small things, which are nothing great, but I think each of these machines, we should be getting it. If you are not having it, whether it's the point of care machine, whichever machine you are using, or the lab machine, you should actually have that printout from the NGSP website, which is freely available.
Thank you. Thank you, Sujay. Anybody else wants to add on point of care? Should we go to the next question as such?
It depends.
Yeah.
Carry on, Shashank.
I'll make just a small point.
We have this seasonal variation in our part of the country, in Haryana. These machines do well in winter, but in summer the results are awful. They go off track, and sometimes when we have done phase 2 and phase 3 trials, we've had to put the point of care machine on an ice slab to get a good value.
Oh.
And this we did because we had to do the particular trial, and the trial mandated it. Those are the kind of things. Last month I had a patient, she got a random glucose done. It came out as 140, 150. Somebody got an HbA1c done. That came out as 8.3, 8.9. She was diagnosed as having type 1 diabetes, a 22, 23-year-old girl. And actually, when we did the hemoglobin electrophoresis, she turned out to have something called hemoglobin Punjab. That was giving the false positive. So you have to be very careful while diagnosing diabetes. Just remember that the ADA also says, if you have a symptomatic patient, then one abnormal value is enough, whether it's a random glucose or a post-load glucose or a fasting or an HbA1c. But if you have an asymptomatic patient, then you need 2 abnormal values to diagnose diabetes, and preferably they should be from two different types, like a fasting and a post-load, or maybe a post-load and an HbA1c. So just remember that. Don't rush to diagnose diabetes just based upon a single abnormal HbA1c.
Yes, Dr. Joshi. Yeah.
So very quick point of care tests, as Sujay rightfully said, should be appropriately used. but I don't think they are standard of care even in clinics now. In the beginning, a lot of people use them as a part of a clinic or a trial program. But I think over a period of time, we are doing a whole conglomerate of tests in which we are getting a reasonably reliable A1C from the lab. So then to keep an extra point of care test doesn't matter. But probably a lot of these camps are held. My only suggestion was on the camps. And many of these camps we pick up and we do an ordinary glucose meter. But sometimes keeping a point of care A1C might be much more meaningful, particularly because many of these camps, a lot of diabetics conglomerate. And to delineate the diabetics from the non-diabetics, this point of care sometimes is useful. That's the only one point I wanted to make. Thank you.
Just continuing with that, I think we did a diabetes fair a couple of years ago in Kolkata, and we had these two different kinds of counters. One was at the very beginning, they told us that we are known diabetics, and others who came in who did not know anything. The ones who came in had a random blood glucose done. So anybody with a random blood glucose less than 100, we assumed that this individual was not diabetic. But the ones who had more than that, we then did a point of care A1C just to make sure, the point that Dr. Joshi was making, that are these people who should be subjected later on to actually a standardized test of having diabetes.
True. Dr. Sethi, would you like to add? Or?
I think point of care used properly may be okay, but what happens with glucometers is the patient thinks that this is all. And if HbA1c is also done the same manner and fashion, he'll forget about creatinine, albumin, and lipids. That is a problem. If you want to do point of care, you want to do, the patient thinks that everything is done for him, which is wrong. So if you are using the same instrument as standard and you are doing it the way that you would measure HbA1c, otherwise it's okay. But I don't think that this should replace other tests. And the more the number of tests you do in the clinic, the less the patient wants to go to the laboratory. He thinks that those tests are redundant. And the question here is of say urine microalbumin. Across the country, you find people would be getting a serum creatinine done, but albuminuria or albumin creatinine ratio, people don't get it done.
Thank you, Dr. Sethi.